just like run it around to people that want to ask questions. Yeah.
Yeah, and you know how to do that.
No, but
Good morning. Today's really a great day for Kansas City University because it marks the first of our series of ethics lectures. This year, we are going to be bringing in really a whole series of great speakers from around the country, holding their presentations here at the university. But also, just as we are doing today, we will be broadcasting these live, also the lives of the people that are talking, over the internet. So right now, you all are on iTunes U as well, being broadcasted live. So we're kind of excited about that. Today's topic concerns something that really has been a part of American culture for centuries. And it centers on marijuana. And I thought I knew everything there was to know about marijuana when I watched the 1936 movie Reefer Madness. And I thought that was everything I needed to know and would never let anybody touch this stuff, right? But then I'm also a child of the 60s where I went to high school and college, and the world was very different then, too. There are a lot of different sides to marijuana. If you grew up in the 60s like I did, your initial thoughts were, wow, this is a pretty good drug to take to get high on. Also, if you wanted to gain weight, because it really made you eat Cheetos a lot. But then somewhere in there, when I started in medical school and started seeing patients, I learned that patients used marijuana for a lot of different reasons. One of which was sustained nausea and vomiting associated with chemotherapy, and it occurred to me, well, why isn't it available for those kinds of patients? For many of them, they said that it was the only medication that seemed to work for them. There were other patients who have intractable pain, and the side effects of a lot of the opiates that were in use at the time were just intolerable. And their stories, again, are the stories of people who went to the utilization of marijuana for pain and for a variety of different reasons, intractable headaches. Marijuana seemed to be the only thing that could take that pain away. So what is the real story about marijuana? What is it, and is it a medication? And that's the topic of our presentation today. And we're really very lucky because giving us that presentation is David Casarett, who is a physician researcher and a tenured associate professor at the University of Pennsylvania Perelman School of Medicine. Now, Dr. Casarett had a previous book called Shocked, Adventures in Bringing Back the Recently Dead, and that had just amazing reviews and is really a great read. But he is also the author of a new body of research and a new book called Stoned, A Doctor's Case for Medical Marijuana, and explores the science and story of medical marijuana. Some of the reviews of his current piece of work are really very good. To quote one, a thoroughly researched analysis, Stone brings welcome objectivity to an important but contentious topic. So maybe there goes my reefer madness frame of reference. Casarett applies a unique mix of science, humanity, and even humor to effectively dispel common myths and misconceptions about medical marijuana. Stoned is a valuable resource for patients, healthcare providers, and policymakers. So for all of us to learn more about all sides of that equation, allow me to introduce Dr. David Casarett.
Better? Better, yes, excellent. Hi, welcome. It's great to be here. It's great to be the first in this series. We'll try to be worthy of that honor. Just a quick poll before we start. knowing what you know now about medical marijuana, how many of you are in favor of legalizing medical marijuana? Show of hands. Okay, that's an easy 50%, probably pushing 75%. How many of you are opposed? I'll also give you an undecided option. How many opposed? So a few brave souls. And those of you who are undecided, who are really in favor, you just don't want to admit it, you stoners, you. Okay. So my goal in the next hour is not to try to change your mind. So my hope is that none of you who are either for or against or undecided will have magically made up your minds in the next hour. If you are easily swayed, if your minds are that easily changed, then you're probably not paying attention. Because honestly, these issues are complicated. So I'm not here to try to talk you either into or out of. But what struck me about a year and a half ago when I started working on this book was that a lot of people were talking about medical marijuana. A lot of people had really, really strong opinions about medical marijuana, but most people really had no idea what they were talking about. So my goal in writing this book, my goal in giving this lecture to friends, colleagues, patients, physicians, is not to try to change people's minds or convince them for or against, but to make sure that when people are arguing for or against, whether that's a physician or a patient or a policymaker, at least we're arguing with the same set of facts. At least we can agree on some facts that seem to be true. At least we can agree on what needs more research that we're not certain about. So I'm trying to give you the information to fill in the gaps, so whatever opinion you have, you're better able to defend or support it. So again, not trying to convince you one way or the other, but trying to give you an argument along the way. Also trying to advance slides. Excellent. So a couple of conflicts of interest just to be clear about. I don't take any money from the pharmaceutical industry. And yeah, believe it or not, there is a pharmaceutical industry, which is rapidly becoming a multi-billion-dollar business. A lot of people are getting involved trying to make a buck. I also don't do any consulting for the pharmaceutical industry either. Never have and probably never will. I couldn't resist showing this picture of me in theory that came from a book review. I asked one of the nurse practitioners I work with whether that guy really looks like me. And she said no, which was a relief, until she said, he's much cuter than you are. You don't need to weigh in on that, but one advantage of writing books like this is people get to make fun of your bow tie and everything else. So this is ultimately, I think, the question that we all need to think about, whether you're a patient or a policymaker or a physician, whether we should think about marijuana as a weed, as an illegal drug, or whether it's a medicine, or whether it's somewhere in between. Toward the end of this lecture, I'll tell you that I'm not sure that's the right way to frame this question, and I'll tell you why that is. But at least as a starting point, this is a decent place to begin the conversation. So I told you a little bit about what led me to start working on Stone. It was really, though, a patient conversation I had. I'm a palliative care physician, a professor at Penn. So I get, because I'm the director of the palliative care service, when there are quote unquote VIPs in the Penn health system, retired professors, retired deans who have symptom management problems that get referred to me. And Judith was a retired English professor from Penn who was referred to me with pancreatic cancer, was having bad nausea and pain, was referred to me to try to help manage her symptoms. And in the course of that conversation, Judith asked me whether I thought marijuana might help her medically. And so I gave her the answer that I was taught in medical school, more or less, which is that marijuana is an illegal drug. It hasn't been studied for its medical benefits. It's illegal in the state of Pennsylvania, so I can't recommend it. And there are really no good randomized controlled trials showing it has any benefits whatsoever. So Judith listened patiently to this canned speech, and then she reached over to her bag and pulled out a couple of randomized controlled trials showing that medical marijuana was beneficial for neuropathic pain, which I'll tell you about in a bit. And in that moment, I realized that this retired English professor actually knew more about the science and medical benefits of medical marijuana than I did, which is kind of embarrassing since I'm a palliative care physician and I should know about symptom management. So I promised her that I would read those studies, I would look for other studies, I would ask friends, colleagues, and try to come up with an answer for her. At the end of the talk, I'll tell you what my answer was. But I promised her I would look into it. And as I looked into it, I realized there really wasn't a lot of discussion, as I said before, about medical benefits. Everybody a year and a half ago, even now, honestly, are talking about medical marijuana in terms of whether it should be legalized, whether people should have a right to have access to it. A lot of people are talking, as I said before, about the business of medical marijuana, but nobody's really talking about medical benefits, what it can do, how it can help people, or the flip side, the risks. Nobody's really talking about the risks and whether those risks outweigh the potential benefits. So in a big way, the research that I did for Stone was really stemming from this conversation that I had with Judith. Along the way, there were a number of surprises that I came across. And rather than walk you through chapter by chapter or some more organized way of thinking about this topic, I thought I'd walk you through 3, or depending on how you count them, 4 surprises that came to me as I was researching Stone. The first is that there's a science of how marijuana works. It turns out it's not just about making people stoned and making people forget that they're in pain or nauseated. There's also, by the way, this is a twofer, there's also a science to how you use it. There's some ways of getting the cannabinoids, the active ingredients in marijuana, into people that work, other ways of getting them into people that don't work. There's actually a whole lot of science there, just as there is science to absorption of amoxicillin or opioids or any other drug that we use. So that's surprise number 1 and I guess number 2. The second surprise, which Judith got me thinking about, was that medical marijuana really does have medical benefits. And I should say that there probably aren't as many benefits as some of its most ardent proponents claim, but there are probably more benefits than some of its opponents will admit. So the truth is somewhere in between, and I'll show you briefly what those are. And then last but not least, marijuana does have risks. Again, probably not as many risks as the reefer madness aficionados would have us believe, but there are also more risks than some of the people who are making money off of selling marijuana would like us to believe. So somewhere in between. And I'll try to give you a sense of what I think those risks are, which are real, which are probably false, and then which we don't know about yet. And then I'll try to wrap up at the end by giving you some sense of how I've come to think about medical marijuana, how we should think about it, how we should talk about it. Is it a medication? Is it a weed? Is it an illegal drug? Is it a wonder drug? How should we begin to describe it? How should we begin to regulate it? And then if we have time for discussion, maybe we can talk about whether legalizing medical marijuana makes sense. So there is a science of how medical marijuana works. And I'll walk you through that first, and then we can talk about benefits and risks. So one thing to know about marijuana is that there are 2 species. Some people would say 3, but the 2 main species are indica and sativa. And the reason that people think about those species differently is that by and large they have different chemical components. So sativa strains are much higher in THC, tetrahydrocannabinol. THC is the ingredient of marijuana that makes you feel high or stoned. Lower concentrations of cannabidiol or CBD, which has, we think, anti-inflammatory properties but doesn't have any psychoactive effects. So using strains that come from sativa species have high concentrations of THC are more likely to have those psychoactive effects, whereas indica strains are the reverse. So in general, higher concentrations of non-psychoactive CBD, lower concentrations of psychoactive THC, so less likely to get that stoned and euphoric feeling with indica than you are with sativa. Having said that, though, if you actually look at the plants, and in the process of researching Stoned, I went to many agricultural operations, growers, some legal, some not so legal. And if you look at these plants, you can't tell the difference, or at least I can't tell the difference. It's not like indica species look like this and sativa species look like this. They're all kinds of shapes and sizes. The other thing that's interesting is that that rule that I just gave you, that sativa strains tend to be higher in THC, indica strains seem to be higher in CBD, that's statistically true overall. But there's so much crossbreeding and different strains that you can certainly find a lot of sativa strains that are really high in CBD, low in THC, and the reverse is true. We'll get to that a little bit later. But it's important to know that if you're working with a patient who's saying that I'm using this particular strain, which is this particular species, to treat my pain, nausea, whatever, because I'm looking for a strain that's high in CBD, they may be getting that, but they may not be unless you're actually testing for it. So a lot of what you read actually about what sativa strains look like, what indica strains contain, tend to be general rules of thumb that are probably true more often than not, but they're not true some of the time. So one big lesson to me is that you can't rely on those generalizations. When you're getting the cannabinoids, THC, CBD, and others from a marijuana plant, you're actually getting them from these guys here, these little things called trichomes. They're less than 1 millimeter long. They're present in the buds mostly, but also sometimes on the undersides of leaves. And they're little appendages that look like little nail heads if you look at them up close that are really, really high in cannabinoids, CBD, THC, and others, but mostly THC and CBD. And that's Miss Sativa, because when you're looking for plants with high concentrations of those trichomes, and therefore high concentrations of cannabinoids, THC and CBD, those tend to be more present on female plants. So in general, whether people use it recreationally or medically, the buds, the trichomes, are harvested from female plants. So what's in a bud? Lots and lots of cannabinoids. Actually, that third point is probably the most important. There are dozens of cannabinoids that have similar structures, those 3 rings with variations. Lots of cannabinoids. The ones that are present in the largest amounts are THC and CBD. A lot of those. Those are the ones that have been studied. Those are the ones that have been characterized in laboratories. Those are the ones that have been synthesized. We have some idea of what they do, not a great idea, but some idea. But all of these other cannabinoids, present in smaller amounts, we have no idea. And so the key take-home point there for me was that when people talk about the key ingredients of marijuana, they're saying THC does this or CBD does that. Well, yeah, that's true, but you're taking 1 or 2 molecules out of a really complicated mix. And there's a big difference between taking 1 molecule out of a plant versus that plant. Maybe those cannabinoids don't do anything, or maybe they have important effects, or more likely, maybe some of those other cannabinoids modulate the effect of THC and CBD in ways that we don't understand. So I'll talk a lot about THC and CBD, but keep in mind that's not the same thing as the entire plant. And one interesting study looked at chronic marijuana users and found that people who smoked more marijuana, higher concentrations of THC, had more long-term memory problems. Just one finding. The interesting thing, though, was that people who smoked marijuana that had higher concentrations of CBD actually had less of an effect on memory. So the presence of CBD in that admittedly descriptive study, not a randomized controlled trial, suggests that CBD might not have any psychoactive effects on its own, but it might have some effect on what THC does to your brain. Just one example, but it's an example to illustrate the fact that what's in a plant is much more complicated than just 1 or 2 molecules. So how does marijuana work? And the answer to this is fascinating to me. 2 pieces to this. One is there are receptors that bind to THC or CBD or both. In general, and this is a huge generalization, but in general, THC binds to CB1 and CB2 receptors. CB1 receptors are present in the brain on neurons. CB2 receptors are present elsewhere in the body, predominantly, we think, in the reproductive system. We, by the way, have no idea what effect THC cannabinoids have on the reproductive system. None. Male, female, receptors present in both, but nobody has any idea what they do. We have a general idea of what CB1 receptors do in the brain. That's what makes you feel high, stoned, euphoric. Those CB1 receptors, by the way, are present pretty much everywhere in the brain. In the cortex, the amygdala, the hippocampus, where they have effects on memory. One part of the brain they're not present, though, is the brainstem, the medulla. Why would that be interesting? Does that have any implications for either benefits or maybe safety? Think safety.
For your respiratory rate?
Respiratory rate, right, exactly. So the way, backing up a step, the way that opioids or benzodiazepines cause a fatal overdose is generally they suppress your respiratory drive, which comes from the brainstem. So an overdose of opioids will kill you. An overdose of benzos will kill you. An overdose of marijuana might make you agitated, anxious, paranoid, but it won't kill you because it won't suppress respiration. So in that sense, at least, we'll get into safety later, but just in terms of receptors, in that sense, medical marijuana or recreational marijuana doesn't have that big risk that opioids or benzos or other drugs do. There's actually a study that came out about a year ago, and I think Archives of Internal Medicine, that found that in states that had legalized either medical or recreational marijuana or both, utilization of marijuana went up, but fatal overdoses due to opioids went down, presumably because at least some recreational users of opioids inappropriately were switching to marijuana. There may be other downstream negative effects, but at least those opioid overdoses were diminished. So those are receptors for THC. CBD is interesting because it doesn't bind to any of the receptors that are on neurons in the brain. And yet, as I'll show you later, there may be a significant effect of CBD on pain. So nobody's quite sure how it works, except there are probably other receptors, some of which we're discovering, some of which we're not, most of which are outside the brain, with one exception, and that's the microglial cells in the brain. So those are the immune cells in the brain that have both an immune function, modulatory function, and also provide some structural stability for the kind of packing that encases neurons in the brain. We didn't really think that those microglial cells did much neurologically. They have an immune function, yeah, they're structural, yeah, but they don't really have much of a neurologic function. It turns out they probably do, and that CBD might exert whatever neurologic functions it has, not euphoria, but other functions, by binding to those microglial cells. So we know a lot more about THC than we do about CBD, but CBD research is catching up. Last science question that I wanted to answer, which I'll share with you quickly, and that is how marijuana works. So we're not born, actually, with receptors that bind to THC and CBD. And I told you which receptors we think they bind to, but those receptors aren't designed to bind to THC and CBD. It's not like we evolved magically to respond to marijuana. Although I think some of the most ardent proponents of marijuana think that there's some sort of magical symbiotic relationship. There's really not. What there is, though, is what's called the endocannabinoid system. So it's a system of receptors and neurotransmitters. Anandamide from the Sanskrit, known as the bliss molecule, 2-AG is another, and several more. These are neurotransmitters and hormones that we all have in us that have a variety of effects, ranging from maybe development of personality, probably the development of systems of weight gain and loss, probably the immune system, and then other effects that we don't yet understand. And when you eat or inhale or otherwise ingest the active ingredients of marijuana, THC, CBD, other cannabinoids, you're essentially tricking your body into thinking that what it's looking at is anandamide or 2-AG or other molecules. In other words, you're using those cannabinoids to hack into this endocannabinoid system. In the same way that we're not born with morphine receptors, right? Like we're not designed to respond to morphine. We are, though, designed to respond to a category of molecules called enkephalins. And when you use morphine for pain management, you're essentially tricking the body into thinking that what it's looking at, what its receptor is looking at, is an enkephalin, when in fact what it's looking at is morphine or oxycodone or fentanyl or whatever. So the same system. What's interesting about this, though, is, as I said, those neurotransmitters, those receptors, are present all over the body. So when you expose somebody to marijuana, you're not just making them stoned. You're affecting this endocannabinoid system that's in virtually every organ of our bodies. And if you're interested in the medical benefits of marijuana, that's really exciting. If you're worried about the risks of marijuana, that's pretty frightening because people really have no idea what any of these receptors do. And that's actually a really interesting dividing line in this history. And some people look at the endocannabinoid system as this great source of untapped knowledge and potential therapeutic value. Other people look at that relationship with the endocannabinoid system and say, you've got millions of people using marijuana, tapping into the system with no idea what it's going to do. So should we be excited or scared? Probably a little bit of both. So second surprise, getting out of the science now a little bit into how you actually use this stuff. And like I said, there is actually a science to how you use it, which I didn't really expect. So a couple things to know. One is that the concentrations of THC, which is the psychoactive cannabinoid, have gone up pretty dramatically over the last 20 years. If you look at studies of THC concentrations in marijuana that's been legally confiscated, mean concentrations about 20 years ago were 2-3%. Now, in some studies, some of the mean concentrations are 10 or 15% or more. So that 2 to 5% range is at most a guess. And the reality is both probably higher, honestly, and probably more variable. And that's important because if you're a patient or you're a physician making recommendations to a patient, you really want to know what that concentration is. If the mean concentration of a bud is 2%, maybe a concentrated strain might be 4%, a lightweight strain might be 1%, that's a pretty small range. But if you're talking about a mean, which in some dispensaries is pushing 10 or 15%, that means you could get a 3% strain at one end or a 30% strain on the other, which means that some of our patients are using this stuff and they have no idea what they're getting until they've already used it and they're way too stoned, which sometimes is not what they wanted. There are other forms in which THC and CBD can be delivered. One is called hash, which has been around for millennia, which is a concentrated form. Remember those trichomes? Imagine a process by which you take those trichomes off of a plant, out of buds, concentrate them, and you get this sort of oily substance that's higher in THC and CBD concentrations than a bud is, but is still maybe 25, 30, 40%. There are forms which is generally smoked, although it can be eaten as well. And then there are other forms called shatter or wax or butter, all sorts of clever terms that dispensary owners have created, which is a highly concentrated form of THC and CBD. Again, those trichomes, but often concentrated using either CO2 or other solvents to get concentrations of 70 or 80%. And those are usually smoked in something that looks kind of scarily like a crack pipe, actually. The other thing to know about how you ingest marijuana or how you don't is bioavailability. So if you use marijuana products by mouth in the form of a pot brownie or whatever, which are available at medical dispensaries, the PO availability is only about 10 or 20%. So you've got 20 milligrams of THC in 1 square of a pot brownie, you're only getting about 10 or 20% of that. If you inhale the same quantity of THC, for instance, in a joint, you're getting 2 to 3 times that much. Wide inter-individual variability. So you and I might either take it orally or in a smoked or vaporized form and get very, very different blood levels. The other thing to know is about this difference here is that this arises because of the first pass effect, right? So anything that you take by mouth takes a while to get absorbed, winds up in the mesenteric veins, goes through the liver, and for many drugs, including THC and CBD, they undergo that first pass metabolism. There's actually 2 steps there. I didn't want to bore you with too much biochemistry, but the first step is a fairly minor modification, and the first modification, the first metabolite of THC, for instance, is still as psychoactive as THC is. But some of that then, in subsequent passes through that same pass to the liver, gets modified again into a form that's inactive. So you wind up losing about half of the psychoactive effect of THC when you use any THC-containing product orally. You miss that, by the way, if you administer highly concentrated forms of THC, say in alcohol drops, under the tongue. You know why that is? Capillaries, right, it's absorbed. But why do you avoid the first pass effect if something's absorbed under the tongue? Right, you skip the liver. It's a weird artifact of anatomy that things that are absorbed rectally, at least distally rectally and sublingually, bypass much or all of that first pass metabolism, which is important for many of us who work in hospice. Sometimes when people can't take PO drugs, we would switch to either sublingual or rectal administration, and we need to adjust the dose because you're essentially eliminating that first pass metabolism. And the same exact thing is true with marijuana. A couple of methods of administration. Smoking is the one that's I think most widely known. We'll come back to some of the risks of smoking in a minute. But one thing to know, and one thing that many people say is an advantage of smoking, is that the rate of uptake is so fast that within literally 10 or 15 seconds, you're going to get peak plasma levels. And I'm not portraying that as a benefit in terms of pain relief, although some people claim that. But the real benefit, to my way of thinking, is that it gives patients an opportunity to titrate the dose. Within 15 to 20 seconds, you know how much you're getting, you know how concentrated the THC is in that bud, and if it's more concentrated than what you wanted, you can stop smoking. Compare that to eating edibles, for instance. You eat a brownie or a square of chocolate or a gummy bear or whatever, and you begin to feel the effects maybe in 30 minutes, 45 minutes to an hour, and many people I've talked with didn't feel the effects that they wanted in terms of pain relief or nausea relief or whatever after 30 minutes, 20 minutes, and so they would try another brownie or another gummy bear. They still wouldn't find the relief they were looking for, so they'd try another. And all the while, you're stacking up these doses, right? Because you haven't hit a peak plasma concentration for any of them. So an hour and a half in, 8 or 9 gummy bears later, then those effects start to kick in. It's a little bit too late to do anything about those except to lock yourself in a closet and take a nap for a good long while and hand somebody the car keys. So that's, I think, a big difference in administration. For somebody who knows exactly what their dose is, that's fine. But for somebody who's new to the game, a new patient, it can be a problem. Another method of administration goes back 150 years, but it's one that we're still using now. This is a guy named William RShaughnessy, who was a physician who was stationed in Calcutta in India in the 1840s. And he became interested in a lot of people who were using recreational marijuana in Calcutta back then, realized what its psychoactive effects were, and started thinking that some of those calming psychoactive effects might be useful for some of the patients that he was treating, ranging from weird diseases we don't see much these days, like rabies or tetanus, to patients with what sounded like, from his descriptions, florid schizophrenia or other complex pain syndromes. So he wanted to try to figure out how it worked, wanted to try to figure out what the optimal dose was, because he was a physician and scientist. So wanted to use animal studies first, wanted to start with dogs and, for some reason, goats. He ran into a problem because the way that everybody he saw was using marijuana was smoking it. Think about the logistics of trying to get a goat to smoke a joint. There's probably a way to do that, but he was not bright enough to figure that out. So he made what's called a tincture, which is high concentrations of THC and CBD cannabinoids dissolved in really, really small concentrations of alcohol. Not brilliant. There are tinctures available of lots of other drugs back then, but he was the first, as far as I know, who used a tincture as a way to deliver the active ingredients in marijuana. And the reason that was so brilliant was not only could he administer marijuana in that form to goats, and I mean, come on, if you know a goat, haven't you ever wanted to see a goat when they're stoned? That's got to be a dream of many of us. It certainly was for him. But the other crucial advantage is you know exactly how much cannabinoids, THC and CBD, this is back before the days when he actually knew what THC and CBD were, but he knew that if he gave 2 drops to one patient one day and then 4 drops to that same patient the next day, that the second dose was exactly twice as much as the first. It seems like a fairly minor thing, but if all you're seeing is people smoking joints, how do you figure out, as a physician, as a researcher, how to come up with a reasonable dose? So that was his main contribution, which we're seeing now. So there's a company called Sativex, or a company called GW Pharmaceuticals that makes Sativex, that goes by other names too, that is essentially what O'Shaughnessy created. It's a tincture of plant-based marijuana products, THC and CBD, which is approved for use in the UK, in Canada. I think it's in clinical trials here. It's not available yet. But a lot of people are interested in using tinctures now as a more medical, more scientific way of delivering the cannabinoids and THC. So I've mentioned edibles a lot. There are a lot of ways to get cannabinoids into edible products. And I've met a lot of patients who are older, who wouldn't want to be seen smoking a joint, but would be very comfortable using edibles. Squares of chocolate, I think, are by far the most common. It's socially acceptable. People who even have significant moral, cultural reservations about medical marijuana are willing to try a square of chocolate, but you can get pretty much everything else. The future of medical marijuana administration, though, is getting really, really interesting. And I was talking to an entrepreneur who's starting a company who explained to me that he wanted to be the Levi's of the medical marijuana industry. And I had no idea what he was talking about. And a little bit of research, though, made me realize what he had known and been thinking about a lot was that the guy who invented Levi's, who I never really thought about it, but I guess his name was Levi. Yeah, okay. Saw all of these miners coming through California and San Francisco, didn't really feel compelled to open up a mine himself, didn't feel compelled to do the hard work of actual mining, but realized that all of these miners walking through needed rugged, dependable pants, I guess, and jeans jackets, I suppose, handbags, whatever. And so that's how he made his money. Didn't waste any time mining, but made products that these miners would want. And so there are a lot of entrepreneurs now who don't necessarily want to get into the medical marijuana dispensing business, but they're realizing that everybody who's using medical marijuana wants some device to use it through that would give them a reliable dose. So there are a lot of products on the market. One of the most popular is a so-called volcano. The method behind many of these devices is elegantly simple. You essentially heat the marijuana product, which is usually a bud, to a temperature that's high enough to get THC and CBD to vaporize, but not so high that the material in the bud actually starts to burn. So it's kind of like distilling alcohol, right? You heat a mixture of alcohol and water to a temperature that's above what it takes for alcohol to evaporate. The alcohol evaporates, the water stays behind. In the same way, you get the benefits of THC and CBD in an inhalable vapor without the smoke and tar and particulates that you get when you burn marijuana. Lots of different forms, vape pens, other devices that are out there. Many of these work, some of them don't. Most of them we just have no clue. Like how much of the CBD and THC in a volcano actually gets to a person, no idea. Because these are recreational devices, they're not medical devices. I think that's going to change. But something else for us to keep in mind as physicians, as we're taking care of patients who are telling us how they're using this stuff, well, it depends not only how you're using and what you're using, but what mechanism you're using as well. So one last point about how to get the active ingredients of medical marijuana into people, because it's an important one, and it's one that there are a lot of misconceptions about. In order to get the active ingredients of medical marijuana, THC, CBD, other cannabinoids, into people, you need to get them out of a bud, unless you want to actually smoke the bud. So if you're looking at edibles, brownies, gummy bears, whatever, you need some way of extracting those cannabinoids from the bud and getting them into that edible. And it turns out there are really two ways to do that. Either way, you have to give those cannabinoids something that they're soluble in. And the two things that cannabinoids are really soluble in, categories, are either alcohol or lipids, fats like butter or olive oil. So those people who claim that they're making marijuana-infused beer doesn't work. There isn't enough alcohol there actually to get the active ingredients of marijuana out of the bud into the beer. And I confess, for the book, just for the sake of research, I had to try, of course, marijuana-infused beer and wine, and it does absolutely nothing. The beer, by the way, tastes absolutely disgusting. The wine tastes like wine, but it doesn't do anything. Also tried marijuana-infused tea. Again, the same deal. Water doesn't do the trick in getting those cannabinoids out of the bud. So what you need is really high concentrations of alcohol, 50, 60, 70%, or lipids, fats like oils or butter. Okay. So a little bit of the science about how to get the active ingredients of marijuana into people. Now the interesting part, the medical benefits. I was really surprised that there actually are medical benefits. Again, not as many as some people claim. This is what one dispensary owner told me. It's not true. It's interesting, though, that this is a guy who's made, in the last couple of years, millions on millions of dollars by selling patients on this claim. So I think for us as physicians, that's also something to be really, really scared about. Our patients are hearing from dispensary owners and from their friends what wonderful things medical marijuana can do, of which a few are true, but most of which are not. If you look at state laws, most medical marijuana laws say this substance can be used for these approved conditions. These states all have these lists, and if you try to crosswalk these lists, you get very confused very quickly because each state has a different idea. So apparently marijuana works for PTSD in California, but it doesn't work for PTSD in Colorado. Like, it doesn't make sense. Either it works or it doesn't, but states have their own laws and their own views of the data. So it's really, really hard to sort out from state laws what's actually useful. Another warning to us as physicians, our patients won't be able to rely on state laws. We won't be able to rely on state laws for approved indications. We'll need to understand the evidence ourselves. So just to give you one example, this was an article that came out in the Journal of the American Medical Association about a month and a half ago now, which is a systematic review of the benefits of cannabinoids. Some of those studies included smoked marijuana or vaporized marijuana. Some of those studies included natural cannabinoids in isolation, THC, CBD, and some included synthetic cannabinoids made in a laboratory. So very, very different, and some were combinations, some were just one drug. So it was a very, very heterogeneous meta-analysis, but they tried to pull all those studies together, 90 some odd, I think, in total, to draw some conclusions. And I won't walk you through all of them, but I'll just hit a couple of highlights because that gives us some sense of how we as physicians should begin thinking about this stuff. One answer is they didn't find as much evidence as I think many people like that dispensary owner would have hoped. Moderate evidence, they said, for neuropathic pain and spasticity, muscle spasticity, for instance, in multiple sclerosis. Lots of actually decent randomized controlled trials for MS. Weak evidence for nausea, weight gain, sleep, and some other indications. I was interested by those conclusions because although I think those levels of evidence is something that I would more or less agree with, there's probably more evidence for neuropathic pain and spasticity, say, than there is for nausea. And I really thought there was actually pretty good data for neuropathic pain. So I decided to unpack one of the studies they looked at. This is a study, by the way, that they said was low quality, and they weighted it accordingly in that meta-analysis. This is by a guy named Barth Wilsey, who I met researching Stoned, an anesthesiologist at UC Davis in California, and also a pain researcher. And he heard lots of stories from his patients about how marijuana was helping their neuropathic pain. So that's pain, right, due to nerve damage as opposed to nociceptive pain. Really hard to treat, pain that results often in patients winding up on half a dozen or more medications that cause side effects, doesn't respond really well to opioids. So a lot of incentive for us as physicians and researchers to figure out how to manage that pain better. So he's been doing a series of studies on either smoked or vaporized marijuana for neuropathic pain. This is one study that I thought was pretty impressive, which they called a low-quality study. So I thought it was good because it was a randomized controlled trial, placebo-controlled, there was blinding, and yeah, you can actually get placebo marijuana. You can extract the THC from marijuana and CBD in much the same way that you extract caffeine from coffee. It's usually a solvent or liquid CO2, and you can make it essentially decaffeinated marijuana. And they also use low and high test groups to examine dose effects. But they called it a weak study, low quality study, because there were only 39 subjects and because blinding was imperfect. Well, it was a small study because there's no federal funding for medical marijuana's benefits. So you take away federal funding, it's really hard to do large-scale studies. So that applies to pretty much all medical marijuana research. Imperfect blinding, well, of course blinding was imperfect. I mean, if you don't know whether you're getting marijuana or oregano, you're probably not paying attention, right? So you can't really do a good blinded study of marijuana. So yeah, those were weaknesses, but they're weaknesses, the size and the blinding, just to take two examples, that apply to virtually all medical marijuana research. So I'm not saying those criteria are wrong, but if you use those criteria, you're basically calling every medical marijuana study out there weak. So it took me a while to figure out what to do with that. And I think the challenge and the ethical conundrum I would give to you to think about and maybe talk about later is that for many of us as physicians, for many of our patients, that's way too much evidence. That's setting the bar way too high. Many of my patients who have tried multiple medications, haven't found any relief, are not only willing but happy to give a try to a medication, whether it's marijuana or a new opioid or whatever, that has one randomized controlled trial supporting it. Researchers, policymakers, people at the FDA, on the other hand, want several large randomized controlled trials, hundreds if not thousands of subjects, perfect blinding. So different standards of evidence. So who's right? Well, they're both right. And I think that's the problem. I mean, if you're a patient and you're desperate and you're not getting relief from medications that have been prescribed, it's perfectly reasonable for you to give something a try, even if there's only one randomized controlled trial supporting it. On the other hand, if you're a policymaker and your responsibility is to protect the public health, then yeah, you'd want to see more clinical trials. So that's, I think, a lot of where the conundrum is about medical marijuana right now. It's not that people are arguing over the evidence, although some people are, I guess. We're really arguing over how much evidence you need to make medical marijuana legal. Will one randomized controlled trial and some evidence of safety do it? Or do you need multiple randomized controlled trials and studies of tens of thousands of people showing safety? I don't know the answer to that, but I think that's the question that I would ask you to consider. The other thing that struck me that's been interesting in all of this is if you're watching the last couple of slides and some of the claims of these dispensary owners claiming that this is really the best drug out there, but there really isn't a lot of evidence, that's kind of weird when you think about it, that it's now legal in 23 states plus the District of Columbia. There are at least 1 million registered medical marijuana users in the country, and for everybody who's actually gone through the process of registering, there are several million more who are using it quasi or illegally for medical purposes. And yet the number of high-quality randomized controlled trials we have is really pretty limited. We don't have any RCT data, by the way, for things like PTSD, which is one of the most common uses. And yet somehow the use and the legalization has gotten way ahead of the data. So why is that? I wrote an op-ed for the New York Times a week or two ago based on a patient I spoke with who I met in a dispensary in California. And she was basically telling me that not only did medical marijuana help her symptoms, but she really liked it because it gave her a sense of control. That she wasn't relying on a physician who may or may not make time to see her and who may or may not write her a new prescription. She could go to a dispensary, try one strain of marijuana to see if it helped with her neuropathic pain. If it didn't, she could go back the next day and she could try a different strain or a different dose or a different mode of administration. The other thing I heard, so it gave her a sense of control. And the other thing I heard from many, many patients was the experience of going to a medical marijuana clinic and dispensary were much more pleasant, supportive, educational, informative, helpful than going to a doctor's office, right? You go to a doctor's office, you wait for an hour, you spend 5 minutes with a doctor, you get a prescription. You go to a dispensary, you have a chance to meet and interact with other patients, you hear their stories, you get advice from them. Some patients that I shadowed would spend a half an hour, 45 minutes with a dispensary worker going through their symptoms, ask them questions. It's also a one-stop shop for a lot of patients. That patients would come in, they would go in to get to buy a medical marijuana product, but they would also get advice, they'd get counseling, they'd come away buying books, brochures, they'd get advice about whether this brand of vaporizer or that brand of vaporizer is better, they would buy a vaporizer there. Can you imagine like going into a clinic, getting all of that advice, getting books about diabetic cooking and a video about how to manage heart failure, all in a doctor's office? So there are a lot of things I think the healthcare system, our healthcare system, could learn from the medical marijuana industry. There are a lot of things that are kind of scuzzy, honestly. Some of the marketing, some of the dispensary owners who are claiming that it's the best drug out there, that needs to stop. On the other hand, some of the things that they're doing are things that our patients really want and need that we're not able to provide. So briefly, in the last few minutes, risks. This talk wouldn't be complete without talking about risks. We know about a few. We think we know about a bunch more. A lot of people, though, who write studies about risks have axes to grind. And it's really, really tough, I've found, to make any sense of what we know about the risks. This is one take on the risks of medical marijuana, which is a little bit extreme. Some of you are laughing because you're noticing that he doesn't really know his botany that well. Because morphine, last time I checked, is an opioid. Opioid comes from poppies, and poppies, last time I checked, are also flowers. So again, this is the kind of salesmanship that many of our patients are being subjected to. So what do we know? Driving impairment, definitely. It's certainly as dangerous, if not more dangerous, than alcohol. Addiction, I didn't really think that you could become addicted to marijuana, but you can. So about 1 in 10 people who use marijuana regularly becomes dependent, meaning its use affects their social life, their function, and their work life, despite attempts to quit. And one other risk that's worth mentioning, just because it's not hugely significant, but it's odd and it's very, very well known, and that's hyperemesis syndrome. So a syndrome of nausea and vomiting that appears in people who use marijuana. Resolves as soon as you stop using it, also resolves with a hot shower for reasons that nobody really understands. Weird, because one of the strongest evidence-based uses of marijuana is in the treatment of nausea. I have no idea why that happens, but it's a risk and a side effect that we hear about a lot. Other possible risks, we don't really know. I mean, of these, I would say that schizophrenia, probably not a real risk. There's studies out there that show that even if it is a small risk, it's not nearly as important as other schizophrenia-related factors like early childhood trauma or substance abuse, or particularly family history. Long-term cognitive dysfunction, we don't really know, unfortunately. There's some evidence for that, as I told you before, in long-term studies. The problem is all those studies are of people who use it recreationally. So these aren't like a 45-year-old administrative assistant who uses 1 square of chocolate once a week to help her get to sleep. These are people who start using when they're 22, smoke a joint a day for years, often with other drugs, many of which are illegal. If you begin to see in that latter set of people some cognitive dysfunction after 10 or 20 years, is that really the marijuana, or is that everything else that's going on? And even the best studies don't manage to control for all those things. So I don't really know. I think there's definitely a risk of long-term cognitive impairment, something that most of us would worry about if we use it, but we don't really know. Interestingly, though, not lung cancer, not head and neck cancer, and not lung disease. And does that surprise you? It should. I mean, you're smoking, as most people use marijuana, you're smoking the same kinds of stuff, the tar and particulates, smoke that cause emphysema and lung cancer, right? It's the same plant matter. It's something that can't be good for you. It turns out that's not true. There have been several large-scale studies, many of which have been done by a guy named Donald Tashkin, who's a pulmonologist at UCLA, not a medical marijuana proponent, just a really good lung doctor who got interested in studying long-term effects. Some small changes in some lung measurements, forced vital capacity and FEV1, but not enough to have any physiologic significance and no cancer risk. Any idea why that might be? People are smoking marijuana, they're inhaling the same junk that tobacco smokers do. Tobacco smokers get emphysema, lung cancer, so what's going on? So I think somebody said a dose?
Pack years.
Pack years, right. So usually measure risk of smoking, whether it's cancer or emphysema, in terms of pack years. So I worked in the VA for a long time, and not everybody, but in general, you really need to smoke some hefty doses to induce lung changes. It wasn't unusual for me to see some guys who had been smoking 1, 2, 3 packs a day for 30 or 40 years. Just for the purposes of argument, imagine what kind of shape you'd be in if you smoked 60 joints a day for 40 years. You probably wouldn't still be in school now, and your lung function would be the least of your problems. So it may be that if people actually smoke as much marijuana as they do tobacco, that you would see these effects. There are other reasons. Maybe it's the CBD that has anti-inflammatory properties. It was actually used in asthma inhalers back in the 70s in some clinical trials. Imagine THC and CBD asthma inhalers. Adherence, compliance to asthma regimens would be much, much better if, yeah, that unfortunately never caught on. But so lots of risks we don't know about, but lung cancer, lung disease doesn't seem to be one of them. Lots of flaws, though, lots of case reports. You could see lots of case reports in the literature of somebody who smoked marijuana and had a stroke. Well, maybe they bent down to tie their shoes and they had a stroke, or they ate strawberry ice cream and had a stroke. Those case reports are interesting, certainly, but not conclusive. As we talked about before, there's really inadequate attention to confounding. All the other things that recreational marijuana users might be using, we just don't know about. So one idea to get you thinking about this as we wrap up, and that's ways in which we could try to get more research going between now and the time that the federal government actually decides to start funding medical marijuana research, which will probably honestly happen in the next 3 to 5 years. But remember what I said about 1 million people using it in registered ways, millions more using it quasi-legally. These people are all taking their best guess, using it for indications like Parkinson's or PTSD, for which there isn't any data. So there's some opportunities, I think, for crowdsourcing research to give patients a chance to tell researchers and each other their story. Some students and I created this website, which isn't, you can use it, I guess, if you want, but it's still in beta testing now, so it's not an ad for the website, but really just presented as an idea. We thought that if we could start building this website that would let patients share their stories, patients could learn from each other about risks and benefits, but really they could begin to teach researchers. You know, if you're a researcher interested in studying some problem related to marijuana use, or you're interested in studying some potential benefit, being able to tap into a community of thousands of users to figure out where people are seeing the most benefit, where those anecdotes and stories are, as a way of guiding where the clinical trials should be. Not that if you've got 1,000 people saying it all works for Parkinson's, that doesn't mean it works for Parkinson's, right? I mean, the dustbins of medical history are full of things that turned out not to work, despite the fact everybody believed they worked, like leeches, right? Or many other examples. So just because we have anecdotes, that doesn't mean we have evidence, but it might be a way to fill in that gap until we do have the evidence. So, 3 surprises. There is some science to how you use it, how you get it, what it does. Medical benefits, again, not as many people would hope, but more than some people would think. And then risks, the reverse. So is it a medication? I actually think that's probably the wrong question to ask. At best, it's probably an herbal remedy, meaning it's a plant. I mean, it's not a medication like amoxicillin or ibuprofen where you're taking one specific molecule in a defined dose. And that's not to denigrate the benefits of medical marijuana. There are plenty of herbal remedies out there, St. John's wort for depression, sawtooth palmetto for prostate enlargement, whatever. These are all herbal remedies that seem to work, but calling it a medicine seems to me to be premature. On the other hand, there are some significant benefits of which we understand some, but not others. So I don't know what the future will hold, but I think it's entirely possible that we'll learn more about risks and benefits. And there are probably, honestly, more risks. Some of those risks in the potential category will probably become real as we learn more about them. Some of those benefits in the potential category will probably become more convincing. And honestly, there are probably some things, if this follows the course of typical medicine, there are probably some things that there's some 1 or 2 randomized controlled trials for now that we'll decide 5 or 10 years from now really aren't as beneficial, or for which medical marijuana has been superseded by other drugs. And that's the last caution I want to leave you with. People always talk about marijuana for glaucoma. So marijuana works for glaucoma, but it's no longer recommended by the American Ophthalmologic Society. It was 5 years ago, and now it's not. So why is that? Marijuana hasn't become any less beneficial. It's just that there are other drugs out there that are better, cheaper, safer. And so the association finally decided, despite the legalization of medical marijuana, that it's just not worth recommending it because there's so many alternatives out there that would benefit so many people. So it may be that even for things like neuropathic pain, that will happen with marijuana. It works, but as we develop other drugs, it'll be less valuable. I don't know, but it could go either way. So thanks to many people who took the time to either let me shadow them as patients or as researchers or as physicians. Really a fun book to write. This was a fun talk to give. And thanks for everything you guys do. You look very enthusiastic and optimistic for the future of healthcare in the United States. I've been around long enough so that I have trouble maintaining that kind of optimism for long, but you guys are all ready to go. So there's a big world out there full of people who are either sick or planning to get sick, and go out and do your thing. Thanks. Did you want to do questions, or?
I just have one quick question. We're running a little late, so just maybe one. What did you tell your patient, Judith?
Oh, I'm sorry. I sort of strategically forgot to tell you that. So I actually did some research. She came back to see me a week or so later. She was also a volunteer in our hospice, so I met her in our hospice unit. And I told her that although her pain wasn't classically neuropathic pain, there were enough neuropathic components to her pain, meaning these shooting pains and tingling feelings that make me think that there was some nerve involvement, that I thought medical marijuana could help. I couldn't recommend that because I'm in a state where it's not legal. She couldn't get it legally, but in theory, I said it could help her. And that's when she said, yeah, her grandson gave her a stash of weed and some pot brownies. She'd been using them for about 3 months and thought they helped a lot. So the lesson there for me is that whenever anybody asks me about medical marijuana, I assume that they either have used it or are seriously thinking about using it. And this is an 82-year-old college professor who's both smoking weed and using pot brownies. So if that's possible, then anybody's possible. And part of the lesson there for me is if you don't, as a physician, assume that your patients might be using, whether it's medical marijuana, illegal drugs, whatever, if you don't assume that that's a possibility, because, well, she didn't tell me. Of course they don't tell us everything. If you don't assume that's a possibility, then you can't give them the support they need, and you can't counsel them about risks. So I sat her down and said, great, that is helping for you. Let's talk about the risk of driving, because she was still driving. Let's talk about hyperemesis syndrome, just so you know the symptoms if they come up. Don't think addiction is really an issue, but just let me explain how that works, and then some other potential risks we'll just walk through quickly. But you can't do that unless you know your patients are actually using, whether it's medical marijuana or another substance. So that was the Judith answer.
Just one thing. If you want to buy and read the book that Dr. Casarett is referring to in having researched and written just the past year and a half, I have 7 copies. You can order it from the bookstore downstairs or anyone else. But we do have 7 copies that are on consignment here, and happy to get them to you. The bioethics students are going to join Dr. Casarett for lunch over at Butterworth. We thank you for your talk.
Thanks.